Chapter 8: Human Immunodeficiency Virus and Sexually Transmitted Infections. There are many sexually transmitted infections such as chlamydia, gonorrhea, and syphilis, and these affect more than 4.3 million people in the U.S. annually. HIV and AIDS can be managed, but it's not curable, and the sooner somebody gets help, the sooner they're able to manage their disease, and the sooner they're able to not transmit it to others. HIV, AIDS, and STIs. AIDS was first identified in the 1980s, and the virus was identified in 1983. So HIV is the actual virus, and AIDS is the disease. So that's when someone has HIV that is uncontrolled or has turned into AIDS over time. Some people get HIV from sexual transmission. They can get it from using needles, and some, not likely now, but people have blood transfusions. That was more so back in the day, but it can still be possible in some places, or if someone's getting a vitamin IV infusion. People are fighting and they both have cuts. Like for instance, if they were in jail and there's a lot of blood, sometimes that could happen, but that, of course, also is rare. So when someone has AIDS, they basically have a very low number of T4 cells, which are white cells, and they have low white blood cell counts. So some people have illnesses that show up when they have AIDS, and that would be a specific type of cancer that grows under the skin. It could be in the lining of the mouth, the nose, and throat, and other organs. Some people have tuberculosis. Some people have wasting, where they lose a lot of weight. And some people have, of course, they have the virus in the blood, but some people aren't able to have a great immune response. So if they come in contact with certain viruses or certain diseases, they might get really sick from those as compared to someone who is healthy. STIs. So these are infections transmitted by sexual contact. So HIV, as we mentioned before, is a virus that devastates the immune system or destroys it. And then it could turn into AIDS. Chlamydia is the most commonly reported STI in the U.S. People think of it as a silent disease, but it's caused by bacteria, and it could damage a woman's reproductive organs, and it could lead to infertility if it's not treated. Then we have gonorrhea. It's also almost as common as chlamydia, so it will be second in line, and is also caused by a bacteria. So this will grow in a woman's reproductive tract, in the urethras of both men and women. It can grow in a person's mouth, throat, eyes, and anus. So sometimes people have symptoms, sometimes people don't. They might think they have a UTI, but most people don't experience symptoms as far as women go. But in men, they might feel a burning sensation while urinating, or have white or yellow or green discharge from the penis. Also, if a woman is pregnant and she's untreated, she can spread this to her baby. Syphilis is less common than chlamydia and gonorrhea. It is also caused by bacteria, and this can cause long-term complications or death. Like, you might have heard of people's brains turning to mush, and that's, of course, if someone's had it for decades. So some people don't have as many symptoms as others. Some people are just asymptomatic. But syphilis is contracted through direct contact with sores and through sexual contact with an infected person, and also could be from mother to child during childbirth. These are all things that women are tested for when they're giving birth, well, before they're going to give birth. And it's worrisome because some of these STIs have been deemed to be mostly from populations of men who have sex with men. Risk behaviors. So when it comes to public health, we like to look into the risks of any condition or disease that someone might deal with. So there would be unprotected sex, as in no condom use, and that includes vaginal, anal, or oral. Drug-inducing behavior. So if someone's using IV drugs, then and they don't have clean needles, then they might give it to someone else. Usually, if someone's trying to get their fix from the drug, they use a needle, and they don't always have the time or the wherewithal at the moment to make sure they're using clean needles. And that was one reason why states like Kentucky and Indiana looked into doing the needle exchange program. They weren't trying to say it's okay to use drugs, but they were definitely trying to make sure that people had access to clean needles. Because if we were able to decrease the amount of people that contract HIV, then that's going to be better for the population as a whole. Other routes of exposure to HIV. So this could happen from mother to child. This is less common in the U.S., but it does happen in other countries. So this can occur during pregnancy, birth, or during breastfeeding. Contaminated syringes, and then workplace needle sticks as far as healthcare workers. The global health impact of HIV and STIs. So 68% of the world's HIV infected individuals live in sub-Saharan Africa. And then as far as communities in the United States, there would be Puerto Ricans, and that's from syringe use. It would be from African American women through heterosexual contact. So you might have heard of down low men, and that's how some black women contract this disease, but they don't know that the men were down low. And also in sub-Saharan Africa is heterosexual contact. And as of late in Kentucky, it's more people are contracting HIV before it gets to AIDS from using drugs. Behavior theories / models for HIV / STI prevention programs / research. So people want to look into behavior change when it comes to contracting HIV. So you must have a clearly defined target. You must have knowledge of the person and what they deal with, what their economic conditions are, who their sexual partners are, or how many sexual partners are having, and making sure the person has knowledge on how to protect themselves. Also, it's important that the community adopts the behavior change. So if it's sex workers, making sure they have access to condoms. If it's men who have sex with men, making sure they have access to condoms and, of course, testing. And then also making sure the person has a self-efficacy, the skill, the knowledge, and the belief that they can get tested. And if they are positive, they can get on medication. And if they aren't positive, maybe they can continue their safe behavior. You also want to make sure that the person knows the anticipated outcome, and that will be outcome expectancy. So does the person know what to do if they do contract it, or if they aren't sure if they've come into contact with someone with HIV? There are times where people are drugged at parties, or someone's a victim of rape, and they can go to the hospital and get some medication within the first 72 hours, so that way it would decrease the chance of them actually contracting HIV. Also, to make sure people have access to these materials. So do they have access to clean needles, condoms? Think about the environments that they are in. Do they have transportation to go get help? Do they have pharmacies or areas that they're close to where people will give them clean needles if they ask for it? And then also it's important to think about the barriers that people have that are beyond the person's control, as far as environment, or sometimes lack of money, or they're not in their right mind, so they can't overcome certain barriers. Mentally, you have to think about laws, cultural taboos, stigma. If anybody has HIV or might think they have an STI, they might not feel like they can talk about it with their family or friends or neighbors. And then as far as if their actions are banned, such as prostitution, then a person might not want to seek help if they know that they're a prostitute, because they don't want to get in trouble. from the law. This is a continuation of what I spoke about on the last slide, and these are all on page 234 to 235. Effective HIV prevention interventions. So basically, whatever the intended outcome, whatever you want to end up with, should be measurable and clearly defined. So if you want to decrease the amount of people that contract HIV from drug use, you might say that I want to decrease this by 5%. So this has to be measurable. So you can go out into the community and survey people, test people also, and see if they contracted HIV within a certain amount of time. And those people have to be drug users, IV drug users. Applying the SCM to prevention interventions. So when it comes to social ecological model, we have to think of many different levels that affect a person. We know that everything is not just behavior, especially when it comes to public health. We look at their environment, we look at laws, we look at who they are around and what type of people they are around. We have to look at everything in order to realize what is having an effect on this person. So how much information do they actually know about HIV? Do they know how they can get it? Do they know how to ask for help? Do their sexual partners get tested? Is there stigma in the community? Do people have the attitude of more so it's important to get tested? Or do people think that if you get tested that someone might be dirty? Are there laws that support testing as far as maybe testing being free or easily accessible to people? These are things we have to think about when it comes to public health. These are some examples using the SCM. So individual level, what is their attitude about HIV? What knowledge do they have? Interpersonal, how does their family have? How does their partner perceive HIV? What understanding do they have? Community and societal level, what are the social norms when it comes to HIV? Is there stigma? And then environmental/policy level, what are the structural barriers or benefits that people have? So do people feel stigmatized? Like certain groups, people tried, back in the day they would say HIV is a gay disease, so that would actually make that group feel uncomfortable, of course, going to the doctors because they might just assume that this person has exposure to HIV when maybe they don't have a reason to have any type of exposure to HIV. And then also just being blamed by society. You also have to think about testing and policies and procedures. Like, do people feel like there's anonymity when it comes to testing? Do they feel like they're able to get help if they get a result that they, are scared of or they don't like? Do they understand how long they could live? Do they understand how to protect other people from acquiring the disease from them? Improving patient antiretroviral medication adherence. So we want to look at a patient's ability to take their medication. Are they able to adhere by the directions from their physician? Are people able to take the medication at the correct time, taking the correct dose to make sure they don't forget so they can make sure that they do not transmit HIV to other people? Do they understand the benefit of taking care of their body so that it doesn't turn into AIDS? Do they understand how important it is to keep the viral low? And also to look at their viral load just to make sure that they aren't heading toward AIDS? Do they understand how they're able to transmit it or not transmit it using PrEP or PEP? Prevention of HIV and STI transmission. 13% of the population as of 2022 did not know that they were living with HIV. It's because people don't go and get tested. They might have gotten tested too early for the testing to recognize that they had HIV. People may feel ashamed or judged, dealing with stigma, and they might be in denial about being positive. Medication adherence. It's very important that people take their medication so that way they can protect themselves and keep the viral load low. So then we'll have U equals U, which is something that is undetectable, is untransmissible. So If a person has a low enough viral load, then they are unable to transmit or transfer HIV to someone else, which is great. And then also they'll be more likely to live a healthier, longer life themselves. And maybe it would be great if it doesn't turn into AIDS. So the government has focused on trying to stop the transmission of HIV, and that would be making sure people know their status, so getting people tested and making sure they have access to getting tested. Trying to break down barriers as far as cost, location, and stigma from society. So they want to make sure that people are able to take their medications, that people have access to clean syringes and clean access to condoms. And they want all these things to be free. And they also want to make sure that people know that if they're positive, that they can get help right away, and make sure they understand that it does not mean a death sentence nowadays. And they can live a healthy life and have a partner that they can have sex with, and that person will not is able to have the right and able to live under the right conditions where they are unable to transmit to someone else. So they want to consider the treatment as prevention now, since once somebody gets HIV, you can't change that fact, but you could make sure that they don't transmit to someone else. So prevention programs focus on promoting testing, making sure people are able to get to testing, maybe having vans go around, pop-up clinics, maybe having testing at hospitals that are easily accessible and quick, and then at events like concerts or events when it comes to the community, easily accessible at a community center, a health department. Just making sure people understand that they can go get help. So people teach classes on this. One of the research focuses that I have is talking to younger people about HIV. It would be young adults. And letting them know that they are part of a group that's more at risk, especially thinking about their income and other demographic information, and making sure they understand where they can go get testing and safe sexual practices. So hopefully we can prevent them from getting HIV in the first place. But if they do get HIV, they'll know that it does not have to be a death sentence. And then also we're trying to understand and look into the stigma that people have when it comes to HIV. We want to know what is stopping people from getting tested. And stigma, of course, is a big part of it. And then also we look into the populations that have been in jail. So we also want to reduce high-risk behavior. So that would be somebody having multiple sex partners, or people that have unprotected sex. And then letting people know that once you get a positive result, you can get treatment right away. Or if you have a partner that has HIV, or if a person has been raped, or just in a situation where they don't know if the person was HIV positive or not, that they can go get help. And the quicker and sooner they get help, they might not even end up with HIV if they can get on PrEP immediately or PEP. Health disparities in HIV and STIs. So a health disparity is where one group has more of a burden of a disease or an economic condition or any health condition versus another group. So that's very common in HIV. In vulnerable populations, so those groups that are more at risk are gay, bisexual, and IV drug users. It could be heterosexual women who have an infected partner, some minority populations, and the impoverished. More strategies we have: test and treat. If someone tests positive, then treat them immediately. Don't wait. Back in the day, people were told to wait until there were symptoms, but now even if a person doesn't have symptoms but they test positive, it's better to treat them now, so that way they're able to stay healthier, have a longer life, and they are less likely to transmit it to someone else. Additionally, there's prophylaxis. So there's PrEP, pre-exposure prophylaxis, and that is treating somebody who does not have HIV. They do not have it, but they have a risk of acquiring it. So that could be having a partner with HIV, that could be a sex worker, it could be somebody that was raped, it could be somebody that had a one-night stand or drugs. There are different reasons why someone might have an exposure. So treat them immediately. And then post-exposure, PEP, post-exposure prophylaxis, is for somebody who's negative, but you also want to make sure that they are treated within the 72 hours. So they had some type of exposure through sexual or other contact. Global health challenges. So migration does come up when you think about HIV transmission. People that migrate, usually migration is a difficult process, and people are exposed to environments such as low employment. They're exposed to dangerous environments. They're exposed to be around people that they don't know. So sometimes they are raped or end up in very bad situations. Not all the time, but sometimes they live in high risk environments, and that will make them at a higher risk of receiving HIV or another STI. Also, people that have other illnesses or diseases, which would be a comorbidity, such as tuberculosis, and those that are drug addicts. If they are too high or too stuck on, at the moment, getting their fix for the drug, they might not think about using condoms, or they might trade sex for drugs. And those people that have a drug addiction might have a higher likelihood of drug resistance as far as medication resistance for HIV. And if someone's highly resistant to the HIV medication, that means they are more likely to transmit that HIV to someone else.